Hello, ladies and gentlemen. This is going to be a systematic approach on how we go about figuring out why somebody has a high calcium level. Now, in practice, and certainly on your clinical case scenarios in step 3, you're going to be asked to evaluate a patient with hypercalcemia, typically who came in because they had an abnormal lab result. Now, I suppose occasionally you may get a patient who has kidney stones and they have a high calcium level, but typically in the ER, which is where somebody with kidney stones goes, we're not doing a big comprehensive workup on those patients. We get their kidney stone out of them, we treat their pain, whatnot, and we send them to their primary. This is going to be what happens when that patient comes to you as the primary care doctor, okay? If you haven't had the opportunity yet, please consider subscribing to my Patreon. You can click the link below in the description of the video, or you can click on the I button in the upper right-hand corner. If you can consider chipping in $1 a month, a little bit goes a long way to help offset the cost of these videos. So thank you very much in advance for your consideration. Let's start with a vignette. We got a 33-year-old woman coming into the clinic for follow-up on an abnormal test result. When she was seen in the ED last week for an unrelated reason, she was found to have a calcium level of 11.2. She currently has no specific complaints. She's on no medications, and I'll add she's also not on any vitamins. Medical history includes 4 episodes of nephrolithiasis throughout her life, an appendectomy at age 23, and a remote history of depression. She doesn't smoke, drink, or engage in illicit drugs. She's never been pregnant, and she's monogamous with her husband. Now, when you get a vignette like this, let's say you're doing a clinical case scenario or you're approaching somebody in real life, what you want to make sure that you do is that you put down your impression. What are the problems that this patient has? Well, this is a patient who's following up on an abnormal lab result. So she doesn't have any symptoms. She's just here to follow up on an abnormal lab. So the assessment of this patient is pretty straightforward. It's hypercalcemia. A recent diagnosis of hypercalcemia. And that's it. So now what you do from this is you make your differential diagnosis. Now, you could have a patient who has multiple problems, and that's going to broaden your differential diagnosis. But for this patient, she's just got hypercalcemia, so we put together our differential for hypercalcemia. What is the differential for hypercalcemia? Well, you should know the number one cause of hypercalcemia is a parathyroid adenoma. This is a tumor of the parathyroid gland that secretes parathyroid hormone, and parathyroid hormone has the effect of increasing calcium, both through multiple mechanisms, by increasing the absorption of calcium, by decreasing the excretion of calcium, and by increasing bone resorption. So by doing all that, it increases the calcium level. There's another syndrome that can cause hypercalcemia, and it's called familial hypocalciuric hypercalcemia. This is genetic. So what happens here is you intake all your calcium, and normally we need to pee out the excess calcium. What happens with these patients is that they don't do that as efficiently, and so they have a tendency to have hypercalcemia. Another thing that can do it is malignancy. So classically, the one that we think of is the tumor that secretes parathyroid hormone-related peptide, PTHrP. And the classic one is squamous cell lung cancer. But there are other cancers that can do it. This patient, we would not expect to have squamous cell lung cancer. She's young, she doesn't smoke, but breast cancer can do it. Kidney cancer can do it. And so we have to keep this in mind. Cervical cancer can do it. So we have to keep in mind malignancies. Bone metastases, that's another one. So obviously if you have metastasis to the bone, most of them are lytic, and so they will cause calcium to go into the bloodstream. And along the lines of lytic lesions, multiple myeloma is another one, although not very likely in this patient. Sarcoidosis. Really anything that causes granulomas, but sarcoidosis would be the big one. This patient would be susceptible. She is a woman, she's young, those patients tend to get sarcoidosis. We have to keep that on our differential. Drug effects. Drugs that cause hypercalcemia would be things like thiazide diuretics, lithium, although she's not on any drugs, so this is probably not going to be part of our differential in this patient, but we would want to consider it in other patients that may be on drugs. And then finally, it could be a lab error. She only had one lab, and maybe it was wrong. Okay, that could always happen. So for that reason, we want to repeat the serum calcium. Now you can do an ionized calcium or you could just do a regular old serum calcium. It doesn't matter. Just make sure you're reading it correctly. Anytime you're working a patient up for hypercalcemia, you want to see the calcium that's in the blood and the calcium that's in the urine, because the calcium that's in the urine is going to tell you how the kidney, whether or not the kidney is appropriately getting rid of calcium. So you want to get a urine calcium too. Anytime you're evaluating calcium, you also want to evaluate phosphate, because calcium and phosphate metabolism are related. So you always want to get a serum phosphate when you're getting a serum calcium. Now, because this patient, we think that there's a possibility that she could have sarcoidosis, we want to get a chest x-ray. If this were an older patient, we would think of the possibility of lung cancer, so we would want to get a chest x-ray for that reason. So a chest x-ray would be good to get. EKG, she probably doesn't have any cardiac anomalies, but calcium disturbances can cause arrhythmia, so for the sake of completion, it may be good to get an EKG, although that would probably score you fewer points on your exam. And then a basic metabolic profile, it tests the other electrolytes, and it's always good to know what's going on with the other electrolytes when you're evaluating anomalies in one. So we get our results. The BMP was within normal limits. The serum calcium was elevated, so it's not a lab error. The urine calcium was elevated, so not only do we have high levels of calcium in the serum, but we're also peeing out a lot of calcium, and that's what we would expect. Serum phosphate is low. Chest x-ray and EKG are normal. Now, I am not going to go into the physiology here, but what I want to point out is that the two mediators of calcium regulation are parathyroid hormone and calcitonin. And I want to point out that calcium stabilizes neuronal membranes. What it does is it increases the threshold potential for a neuron to fire. And so calcium is really stabilizing. But if you have too much calcium, it can be too stabilizing and your neurons can get a little sluggish. And so that's why, as far as the neurologic manifestations of hypercalcemia, we tend to see things like fatigue and maybe decreased reflexes all the way up to coma. Whereas with hypocalcemia, we can see things like brisk reflexes, we can see tetany and seizures and stuff like that. But most mild disturbances of calcium, like in this patient, are indeed asymptomatic. Okay, so you can read this, but I just want to point out here that parathyroid hormone, the effect that it has on calcium and phosphate is that it increases calcium and decreases phosphate. And the reason for that is because parathyroid hormone causes the excretion of phosphate in the kidney. Whereas with calcium, it's increasing that through a number of mechanisms. One, it increases reabsorption in the kidneys, but primarily it increases resorption of bone. Now, calcitonin is what the C cells of our thyroid release when our calcium is low. And so the effect that calcitonin has on calcium and parathyroid, or on phosphate, calcium and phosphate, is that it reduces calcium and it also reduces phosphate. Now you may be wondering why, because parathyroid hormone increase calcium and also reduce phosphate. And you just need to know that, okay? You can look at all these effects and it'll teach you why. I'm not going to go into it here because we're talking about evaluation. This is about step 2 and 3, but if you're taking step 1, you'll want to know the mechanisms of how these work, and I do have another talk where I go into this in more detail. All right. So, disturbances of calcium, we went over the differential for hypercalcemia. As far as hypocalcemia, the number one cause is hypoparathyroidism, typically due to removal of the thyroid gland because the parathyroids are very intimately connected, not connected, but intimately associated with the thyroid gland, that it becomes difficult to take the thyroid out and not remove parathyroid tissue. Another way that you can do this is if you remove the parathyroids. Let's say you have a parathyroid adenoma and you got to take it out. Well, now you can't make parathyroid hormone because you don't have parathyroids. And so naturally that's going to cause hypocalcemia. Other ways that you can get it: low vitamin D, typically through malnutrition, malabsorption, and then diuretics and bisphosphonates, loop diuretics in particular, like furosemide. So the symptoms for hypercalcemia is the mnemonics stones, bones, moans, and psychiatric overtones. So nephrolithiasis, osteoporosis, and demineralization, which can lead to fractures. Fractures can then lead to bone pain. You can also get abdominal pain and pancreatitis. And then as far as the neurologic symptoms, it's hypoactivity. So lethargy, confusion, coma. You can also get the possibility of depression as well as far as a psychiatric effect. With hypocalcemia, it's the opposite. You've got hyperactivity. So you can get paresthesias, hyperactive reflexes, muscle spasms, spasticity, tetany, and seizures. You can also see those two signs that you never see in practice, but you see on exams for some reason, Trousseau's and Chvostek's sign. And then you can get some EKG anomalies as well. So this patient was a 33-year-old woman who had asymptomatic hypercalcemia. She had an elevated calcium, she had an elevated urine calcium, and she had, I didn't put it here, but a decreased phosphate. She had a normal chest x-ray. So what do we know increases calcium and decreases phosphate? Parathyroid hormone. So what we want to do now is we want to confirm that this patient in fact has an elevated parathyroid hormone. And so what we do then is we get a serum parathyroid hormone immunoassay. It'll come up on your possible orders that you can do on CCS or in real life. And so you'll get that, and what you find is 25 milliequivalents per milliliter. Normal is 4 to 9. So we know now that she has primary hyperparathyroidism. Now that was our presumptive diagnosis because of the calcium and phosphate, the normal chest x-ray, etc. Now it is our official diagnosis. So we know then that the patient has hyperparathyroidism, and that it's likely due to an adenoma. So what we know is that the patient is going to need to get this adenoma addressed surgically. But CCS is going to expect you to know what to do for your surgeon. And what you need to do is you need to localize the adenoma so that the surgeon knows where to go. And so what we do to localize an adenoma is we do a sestamibi scan. And a sestamibi scan will look for the adenoma. And so what we see is increased uptake in the left inferior parathyroid gland. Now you know what it is, where it is, and so now we can refer her to surgery for removal. Now, I just want to point out, if you have a patient with acute severe hypercalcemia that are giving you symptoms, then you need to treat it. Okay. Now, this patient, we didn't need to do that because she's asymptomatic. But if you have a patient who, let's say, is lethargic and they're not peeing and stuff like that, then you need to treat them. So the first thing that you're going to do is, first of all, you can manage this in the ED or you can manage this in the ICU, but they're going to need to go to the ICU because you have to closely monitor their calcium, and I'll go into why that is. So the first thing you do is you hydrate them. So IV, normal saline, and what you're trying to do is increase the urine output. That's the first thing you're going to do. You're just going to do that. The next thing you do, if that isn't enough to increase the urine output, is you give diuretics. Why do we give diuretics? Because a particular kind of diuretic, known as a loop diuretic, is calciuric. It increases calcium secretion. And so we would give furosemide. Don't give any diuretic. Don't give hydrochlorothiazide, because that's going to increase calcium resorption, and that's going to worsen the problem. So you got to give furosemide. So start with saline. If that's not enough to increase urine output, then give furosemide. And if that doesn't work, then you can move to calcitonin. Now, the reason that this patient is going to be admitted to the ICU is because we need to do frequent calcium checks. Well, why? Why do we have to check that calcium again and again and again, like every hour? Well, the reason is because you can, by doing this stuff aggressively, you can easily push them into hypocalcemia, and that's bad too. So you want to do the frequent calcium checks, and the only place you're going to be able to do that is in a high acuity area like an ICU. You'll also, it'd be valuable on CCS, make sure that you consult nephrology as well. Okay, so this is our way of going about this algorithm. So you got a patient with elevated serum calcium. What you're going to do then is you're going to repeat the lab. You can do that with ionized calcium or with just regular old serum calcium. You repeat it and you confirm the elevated calcium. So now at this point, you'd want to rule out drugs like thiazide diuretics and lithium. Now, I didn't put these all, I put these step by step, but you'll want to order a lot of these all at once. So you want to order, as we did, the serum calcium, the urine calcium, the phosphate, the BMP, the chest x-ray, etc. That's our basic workup. But I put these separate so you can kind of visualize it. So we have a confirmed hypercalcemia. The next thing that you want to do is you want to get a PTH level, because when you have a patient who's got hypercalcemia, what do you expect their PTH to be? Appropriately, it should be low because PTH raises your calcium. So if you've got a patient who's hypercalcemic and their PTH is high, well, that's inappropriate. So you have something secreting PTH regardless of the calcium level, and so you know that's going to be an adenoma. So primary hyperparathyroidism. And so you can settle on that diagnosis just with that, and that was our patient. Fairly straightforward diagnosis. Now, if it's equivocal, like normal or maybe low end of high, then it would be useful to check your urine calcium. Now, what would we expect if you have hypercalcemia? You would expect high calcium in the urine. You're trying to get rid of that calcium as much as you can. If you have a high urine calcium, it shows there's nothing going on wrong with your kidneys. So that would be a primary hyperparathyroidism. But if it's inappropriately low, then what that means is that the kidneys are not doing what they're supposed to be doing. And so if you have a low urine calcium in the setting of a high serum calcium, that points to that familial hypocalciuric hypercalcemia. Now, we would expect the parathyroid hormone level to be low. And if it is, in fact, low, then the next thing we need to think of are some of those other causes, like the sarcoidosis and the cancers and stuff like that. So what you'll get is you'll get a few different labs. You're going to get calcidiol and calcitriol, and those are vitamin D precursors and active vitamin D. And then you want to get that parathyroid hormone related peptide. So you'll order all of those. And your chest x-ray and whatnot are going to help you, but you'll want to get these three labs. Now, calcidiol is dietary vitamin D. It's also often the vitamin D that's in the vitamins, the multivitamins that you take. So if your calcidiol is high, but the others are normal, the calcitriol is normal, or maybe that's also elevated, but the calcidiol is high, then what you know you're dealing with is vitamin D intoxication. Now, on the other hand, if calcitriol is high, but calcidiol is normal, then what you know is going on is you've got something that's churning out active calcitriol, vitamin D. And what does that? Granulomas do that. Granulomas have that final enzyme necessary to make calcitriol. So if your calcitriol is high, what it's doing is that granuloma is churning out vitamin D, active vitamin D. And so you know that you likely have sarcoidosis or some other granulomatous disease, and that'll probably be apparent on chest x-ray. It could also be a lymphoma, so you'll want to consider those things too. Now, if the PTHRP is elevated, then you want to think of hypercalcemia of malignancy, and you just use common sense. What does this patient look like? Are they a 50-pack year smoker, 60 years old? Then you want to think of lung cancer. If they're a younger woman, you may want to think of, of breast cancer or kidney cancer. Now, if all of these are within normal limits, then you want to consider other causes. And really here what I'm talking about as far as other causes is you want to think of maybe multiple myeloma, maybe bone metastases. And so with this patient, given that she's young, she may be in line for a mammogram. So on the USMLE, you'll probably run into hyperparathyroidism, maybe sarcoidosis, or maybe this FHH or possibly multiple myeloma. Those are some of the more common things that will give you hypercalcemia. And so this should be everything you need to know for hypercalcemia.